if I'm out of breath, I'm 8 months pregnant and I I can barely stand these days, so forgive me. So I'd just like to go over like a little bit of an overview of what it means to be a trauma designation and like where EMS kind of falls into that. So as a level 4, we are designated through the Minnesota Department of Health every 3 years. One of their trauma coordinators and like a liaison from another trauma system come in and they look at our system, they look through case files and make sure that we're following criteria that's designated by the State Trauma Advisory Council. So I'm also a member of the State Trauma Advisory Council and our NERTAC, which is the Northeast Regional Trauma Advisory Council, and we are always looking for EMS members or memberships. So if that's something that anyone would be interested in being a part of, let me or Teresa know and we can get you connected.
I am on it. Just
You
so
are
you know.
on it?
Yeah.
Good. And yeah, so really what that is kind of collaboratively across EMS, hospitals, police, just like public service, working on our state trauma system and the criteria. Part of the requirements is to have a trauma medical director. So we do have a co-medical director who is an emergency department physician and one who is a general surgeon who is ATLS trained. And then we do trauma reviews. I review every case that has an injury, and then I do like small reviews of every case that comes in that could possibly be an injury. So that's about like, for our volume can be anywhere from like 75 to like 90 cases just a month. Keep putting my eyes on it to make sure it's not like a serious injury that does need to go into a registry. And then policy. So as part of a trauma system, you need to have who's staying, who's going, what the criteria is to call that trauma alert. So we create policy and then do education. So part of that is coming out, talking with you guys, collaborating with EMS, and then our post-care too. So St. Mary's, we collaborate closely with them. They send feedback on the trauma patients that we send to them. So I just wanted to review a little bit of our transfer criteria so you guys kind of have an idea of what do we keep locally, what do we not. So if we're looking at this, we have 2 sets of criteria. Should immediately activate emergency transports, and then should be considered for immediate transport. So those are kind of, they don't, each hospital, even within the level 4s of hospitals, have a range of like ability to keep different patients. We do have 24-hour 7 days a week surgical coverage, so we do keep a little bit more than say like Aurora or Cook or Deer Rivers, a hospital that doesn't have surgeons. But a huge deter is that central nervous system. So when you're picking up a patient who maybe was in a motor vehicle accident or even like a fall and you see that their neurals are off, that's really going to be an indication that we need to know so that we can start up transport right away. Different, blown pupils, things like that, or unequal pupils, we're gonna call, flight or backup to make sure that we can get those patients to neurology or neurosurgery. So a GCS less than 11, we're for sure like getting on the phone. So if you can, get that information to us, the quicker we can get them out. Any major like chest or cardiac injury, abdominal, pelvic will take a lot, but one thing, when you start seeing like multiple large organ damage, plus a long bone fracture, plus a clavicle fracture, we know that this is just not something that we want to keep in Virginia. The major extremities, so native dislocated hip, knees, compartment syndrome, things like that, we don't want to keep here. And then that kind of multi-system injury I talked about, and then if we're already seeing that secondary deterioration. Usually that's past EMS. We're here, we're like, you know, we see like an obvious injury, but then we're starting to get secondary deterioration. We got to get them out. And then, of course, so the solid organ injuries, the multi-big two body regions, the comorbidity factors, so if they're very young, or older, have a lot of comorbidities. Pregnancy is a big one. We don't have a NICU. If we're going to need resuscitation for that baby as well, we want to get them out. And then I want to do a case study. So Tree sent me a case. So this was your guys' EMS report. So I'll just kind of talk through it real quickly. So you guys were dispatched to a 53-year-old female, possible broken jaw of unknown cause. When making contact with the patient, she was very off, so neuros were off. There was very noticeable injuries to chin and left side of the face. When trying to have her stand to walk to the ambulance, she was able to stand with help, but not able to ambulate. Patient was oriented to person, place, but not time. And the patient was very sleepy upon arrival and throughout contact. Pupils were uneven in size, reactive, with right pupil being reactive but sluggish. Vitals otherwise remained stable, and the patient was unable to tell anyone what happened. She didn't admit to using alcohol the day before, but denied any alcohol today. Strong odor of alcohol, though, was noted coming from the patient. So just talking about those like immediate transfer criteria, what is like the red flag here? Pupils, exactly. So think central nervous system. Pupils are uneven. One is really sluggish. Like, you know, what are we thinking may be happening physiologically to this patient? Head trauma, perfect. So hospital course. So this is from our hospital, so in Virginia. So we reviewed the imaging and there was an intracranial hemorrhage with a midline shift. It was like did they say how much it was? It was like 3 centimeter or midline shift. So we did consult trauma in Duluth and neurosurgery. Patient remained awake. She was alert and moving all extremities. She wasn't hypertensive at the time. But we're like, hey, we got to get her out of here, obviously. So we got flight to transfer her. They recommended mannitol. We intubated her for airway protection prior to her leaving our hospital. And then before we intubated her, we did can't remember if we intubated her before radiology or not, but we did take some labs. So we had a lactate level that was very high. You can see her alcohol level, so she probably didn't remember drinking or wasn't, you know, like that's a little bit high for saying that hadn't drinking since the day before. And then we have an INR of 1.5 and 17.8 for a pro time. So one of our PI is actually any head bleed or trauma. We really want to, within that first hour of discovery, try to reverse our coags. So that patient did get vitamin K along with K-Centra. We do have platelets. It said no platelets at this facility. We do have platelets, but it takes 30 minutes. So our massive transfusion protocol is not going to be the same as what you might see at like a St. Mary's type facility, just because we don't keep the large quantity of blood that others do. But we typically, if we know they're going to need that massive transfusion protocol, we will call an emergent like blood release. We'll start hanging a couple units, and then if we know that there's going to be a transfer delay, we'll start unthawing the platelets, or else we'll waste a lot here transferring them before the platelets are thawed.
since platelets get dumped in fast, would it be possible to thaw them and then either send the unit with ALS when they transport them or with air medical?
I would say yes, but typically just we don't. I don't like, I'll have to ask about that. We're trying to redo our standard work around that because we share a lot of physicians from St. Mary's, and so they are used to like getting the full massive transfusion protocol, and our lab is they're more conservative and like protective over their blood, you know, so like we're trying to really work on that standard protocol, what it truly means to have a massive transfusion protocol, which should be taking it out and unfreezing. But they typically, we find there's lots of delays even getting blood, and then so by that time, if they're really truly like going to be getting the full gamut, we're hoping that EMS or flight has already taken over, and so we haven't sent. But that's a good question. So this is our patient's image. So yeah, you can definitely see the big subdural there, and then that you can see the midline shift. 1.6 centimeters, sorry. Yeah, so our interventions, we intubated, we protected that airway. We started mannitol on this patient, which is why am I can't think of the word? Hypertonic or exclusion, where it's going to be pulling out that extra fluid and decreasing the intracranial pressure. And so they were transferred to St. Mary's. So I kind of put the timeline here just to show how fast things can go, especially with once we get these patients to a level 1 trauma center. So they arrived at St. Mary's at 1542. Neurosurgery was there at 1600 to consult, and the craniotomy was completed by 1719. So they did go and relieve some pressure. Admitted to ICU. She remained on a ventilator and guarded prognosis for probably till hospital day 5-ish, 4 or 5. She was extubated on the 17th, sitting at the side of the bed. Her current prognosis is she remains in the hospital. She needs to have rehab. She's inappropriately getting up, and there's going to be some TBI issues, I think, with this patient. She's currently on a tube feeding, but alert and oriented times about 2 or 3 right now. So any questions, from just even bringing this case in, or?
Do you guys have any questions? Ask away.
Mm-hmm.
So air medical, mannitol is a blood pressure medication that will help. Somebody with a huge intracranial bleed or whatever isn't able to fly because of that pressure. So they give mannitol, and that decreases the intracranial pressure, so they're able to get into that flight and whatever. And I know for a while Air Medical did not carry mannitol, but I think they both do now.
Yeah.
At one time it was one did and the other didn't.
Okay, I didn't know
But
that.
I think they both do now. So that was that whole mannitol thing. And that the thing with the shift, the bleed with the shift and whatever is really significant. So did they ever figure out our questions, because this was a really concerning call. Everything, there were just very many variables on the scene that didn't fit and they weren't quite right, and just signs of something isn't okay here.
I felt the same way, reading your EMS report to I'm huh, what happened here? But it doesn't sound like case management was investigating as much as I could see from the notes. I mean, I did peek through case management a little bit, but I probably didn't super investigate into that. But I think that everything was done right here. This person needed to stop in Virginia, I think, before, unless you could have got, met flight like pretty soon, because even mannitol is used even in like not just flight situations, but in surgery, preemptively to kind of bring that intracranial pressure to hopefully not have that secondary trauma, like head trauma, in when we have, if you think when you have like a injury, the first injury is the actual hit of the injury, and then you have that secondary deterioration of the swelling, and then it could herniate down through the spinal canal. And so I think they even mentioned possible trapping of the left lateral ventricle, and then worrying of herniation. So really what it is a 3% normal saline, so it's super salty, so it's pulling all the fluid it can. It's it's not something that you would just hang willy-nilly, because you're really dehydrating your whole body trying to pull all that water out, so that so that blood has some, gets pulled out, and then the extra fluid into the vessels and then out. You have to really be careful with the kidneys on this. In this situation, we're not going to wait. Typically, we're not going to wait until kidney function labs come, because, it's this or death, But, you really have to be careful with mannitol if you have, a kidney failure patient that could really create some damage.
Did she have any broken bones? Was her jaw broken?
No.
She didn't have any other?
I don't think so. I wish I had Epic, because I was now I'm wondering, but it pretty much was even if it was, we don't care about it right at this time. But I think even looking at it, she was pretty atraumatic, besides that bleed, so.
Question,
Yeah.
Third one down, craniometry, is that when they drill the skull?
Yep, craniotomy is to evacuate the blood out of your skull. So you're literally getting burr holes to relieve the pressure. Sometimes they'll do even a little chunk, like a flap out, and where just to relieve pressure on the brain. But they usually start out first with the craniotomy.
Gotcha. And the vitamin K was for, I'm sorry, I missed it. What was that intervention for?
So that is for clotting the blood. So it's so our anticoagulants that patients take, I think she had AFib or something, and so she was on Plavix. And so that's a medication that thins your blood, so if you have heart issues, that you're not going to develop clots. Well, we don't want this patient with thin blood anymore, because it's bleeding into the brain. So we give an antidote or a reversal agent to these coagulants or anticoagulants. And so vitamin K, and it's actually called
Starts with a B.
Belfaxor. Is it Belfax? Belfaxor right now? Yeah. Belfaxor is, it's usually called, it's vitamin K is kind of the Kleenex, or the tissue, you know what I mean? And Belfaxor is the Kleenex. It's a brand name of vitamin K, which is helps a clotting factor. But yeah, great question. So yeah, if you think, you have bleeding in the brain, you want to slow that down as much as you can. And so when your INR is high, that means your blood is really thin and it could pool faster.
Gotcha. Now, not to jump the peds, but my daughter got vitamin K, which is more.
Yep. I think that's, yeah. I don't know exactly, but I think that's just kind of a.
Yeah,
Does it have to do with the eyes?
The eyes, they do a different, don't they do they have this little ointment that they put on the eyes.
Yeah.
And then the vitamin K, I think maybe just you're disconnecting from your mother, you don't want to have any bleeding issues.
Sorry.
Yeah, no, it's a good question.
Keep asking.
Yeah.
bodies don't do the vitamin K,
Sure.
like it's like a big thing, or the eye ointment, it's like an antibiotic they put on
Yeah.
the eye, right?
It's
Mhm.
something, yeah, it's something,
Physical, something,
In case of HIV, for the,
Yes.
for the eyes,
yeah.
or, you know, just.
for the running without risk. So
Yeah. I just do what they tell me.
Right,
Yeah.
that is not
what
my
I do.
area.
Mhm. Yeah, so the prognosis is kind of unknown for this patient. I think that she'll probably have some TBI, traumatic brain injury, like issues, going forward, but
What is the discharge on feeding tube with some impulsive, is that the,
yeah, no, so she was, will need rehab following discharge. And then, I should have put a comma there, and is on feeding tubes with some impulsive behavior. So they did start her out with oral, but I think she was aspirating a little bit, so they did, do some feeding tube with her. But, yeah, so she's still she remains in the hospital right now, and will probably need like inpatient rehab for a while until cause right now I think she's on a bed alarm, like trying to get up, you know, still needs a lot of help.
Well, and she had comorbidities too, it like, you know, she had cirrhosis and her
Yeah.
liver and
Mm-hmm.
a severe alcohol problem.
Yeah.
So who knows, you know, what else and how much of that is, you know, pickled brain syndrome too.
Mm-hmm. Yeah.
So, alcoholic encephalopathy, I guess is the right word, but.
Well, I hardly ever look into the inpatient world anymore, because now I'm just like, as soon as they're like, you know, off out of my ED, I, you know, like I seem to look at the trauma itself, but that's, so you bring up a good point, is the comorbidities have like a huge impact on how these people are going to, like, recover down the road. But yeah, it's a sad case, and especially, and it's a weird case, because reading your report, even when I was first reviewing this case, I'm like, I'm like, what happened there?
Right.
You know, it just seemed a little suspicious.
Well,
but-
even outside, you know, they found a little bit of blood outside that looked like it was kicked over, and, you know, but no
but
blood in the
everything
house.
was like
or-
perfect, the house was like, like nothing looked like anybody fell anywhere. It was the
Yeah.
weirdest thing.
And I mean, nothing, no blood or anything on her clothing, and her shirt was only like over her head, not complete. It was weird, you know, the whole thing. Yeah, it was something. So
Yeah.
and maybe we'll never know either. You know.
I'm guessing not.
Was there other
Yeah.
people in the home?
Mm-mm.
Yeah, it was her son and him.
Son,
Her
and then they
son
called in was it the husband?
Yeah,
Who said that it looks like she got hit with a bat?
the husband did. That was his specific. It was just weird, and it really
Weird,
did.
that's oddly specific.
Yeah.
Well, and he had been gone since the day before, and he said that he was at a Super Bowl party, and they went on Sunday at noon, and the Super Bowl didn't even start till 5 o'clock.
Oh.
But
The party might have started earlier.
like the day
Free day.
before.
Mhm.
At his mom and dad's house, and he decided to
Well,
stay
Super
there
Bowl
for the
coverage
night, and
for the
it was,
pregame did start on Saturday.
there was well, see, and we're on the range, we have to understand, we have to
Yeah.
remember that.
You have to
But I mean, there were
prepare.
just a lot of, you know, there were just a lot of things that didn't
It was very
sit right.
unsettling.
Yeah.
It's
Right.
How drunk was he that you didn't really know where he was?
Right, and that could, you know, and that too, so.
It's like one of those things when you walk in and just the way like people act or the way like things happen,
Yeah.
that's what made it so offsetting, I think, is the way that like the whole thing went down.
Now I want to go look back in the case.
If you find anything
I will.
else, shoot me an email and I'll send it to them.
Yeah, just to see it. Yeah.
Thank you for doing that.
Yeah, of
It's-
course. Send me any case that you guys bring and you want to review. Like I probably have already reviewed it, and
Technically, have a PD out there, Grace?
Yes, they were, and
They're
they're
like,
supposed to be getting me information, but there really wasn't any information for them to.
That's good too.
Did you have a
Just kind
chance
of
to
a
review
guess.
the call we had like a month or two ago where the guy fell down 30 stairs?
yep, if he came to Virginia, I did.
He did, and he died.
Did he die?
Yeah.
He
Oh.
died in Virginia, or he died?
I don't know, I just got a
Okay.
request from the ME.
Oh, was
No, I
it
think,
was
no,
it
he
the
got
LaForte
shipped.
fracture? Was that the one?
Maybe an orbital fracture, he had,
Yeah, he was the one who fell down 30 stairs head first.
Okay. I think he was a Lafort fracture, which is like basically like your jaw and like your nose like sinks in. And was he like up and talking?
Yeah.
Yeah. So off the top of my head, so that patient did come in. We like decided to do, we got his imaging. We decided to do intubation, and he like something ruptured and he just started bleeding. We were like suctioning, and I think he did go into VFib. I think we shocked him. We had already called either Virginia or Life Flight. We were gonna send him out, but then we had to bring him back because and then we ended up we like got a hold of family, and we ended up like ceasing in Virginia resuscitation.
Yep.
But that's interesting because one of my nurses she's like, I've been thinking about that case for a long time, and we like cleared him for like C-spine and took his collar off after intubation or before, and then we whatever. And she's like, and thinking of it, like, should we have kept that on with knowing this Lafort fracture, like, because that at least gives it some stability in the jaw. And so I did this big, like, I went and talked to the PI coordinator in St. Mary's and Dr. Scott, who is their trauma surgeon. And I guess there's a lot of different literature on that. They, like, basically it wouldn't have helped anything. It wouldn't have hurt anything. They say that if you can clear it, that you can take it off. But yeah, we were like, I don't know. Like, we kind of did a little.
That makes sense, though, the stability part of it.
So,
Was there like esophageal varices? Did they rupture during the intubation, or?
I think there was just probably so much trauma that, like, yeah, I don't think they ever, unless the ME found something.
He looked like he fell down 30 stairs, too.
Yeah.
But I don't know how much you read into it, but, like, as far as, like, positioning go, I know the ER sat him up, but I laid him down because of C-spine. What's your, like, opinion on that? I mean, either way.
So if we think of like cranial trauma, we want gravity to work with us. So we usually put a patient with the head of bed at 30, but that's, on the field, like getting C-spine and, like that's not going to hurt anything. Usually once they're in the ER and then we know they're going to be, stable or stabilizing or is stabilized, then throwing their head of bed up.
Okay.
So yeah, I don't think, like getting him in C-collar laying flat is totally fine. But yeah, I think anytime we think, head injury, we think that pressure, usually they're, like the blood pressure is going to be like pumping blood to the brain, and we want to decrease pressure. So we're going to have gravity help us, like.
And he wasn't on a board, right? He just had a C-collar on?
Yep.
Yeah. So had the bed at 30 degrees would have been appropriate.
Okay.
Mm-hmm.
Anytime you can with a head injury, it's probably best practice to do that, just in case.
Yeah, I was just unsure about other spinal injuries.
Oh,
because
sure.
of
Yeah,
how
no,
far he fell.
that's a,
Right,
yeah.
that's a hard wall.
He said it was 3 steps, but.
Yeah, he didn't know.
Yeah, he was drinking too, I think.
Yeah.
But yeah,
When he climbed back up to the top, didn't he?
Yeah, well, he had pants on when we got there, but originally we got called up to a naked man and fell down the stairs.
Zeppelin.
yeah.
We call that Tuesday around here. It could be worse.
Yeah, I learned more than I ever thought about those Lafort fractures too, which is, yeah, dangerous, which is, it makes sense. But any other trauma questions? Great questions. And then I also manage the stroke, and so I looked back and I couldn't find like a good stroke case review or a STEMI. So I don't have case reviews, but we can talk through anything that you guys wanted to.
Most of our STEMIs go straight to Duluth.
Yeah.
In fact, almost all, unless it's, whatever. And yeah, I don't know that we've had some minor strokes, but I don't think we've had.
Yeah, I was looking through some of like the big cases and none of them.
Yeah.
Unfortunately, we're getting some of our like bigger cases are walk-ins, so that really like goes to show the community education we need to push out that, you know, like our Be Fast education, and really that stroke is a medical emergency, and to call 911. So a little plug: in May, I'm going to be out, but our critical care unit councils are going to be putting on the Strides for Stroke, which is through the Minnesota Stroke Association. And so we're going to do a virtual together walk. So we're not like a designated site yet, but I'm working on that because I really want to be representative of the whole state. So I want to get one up in Virginia. But it's a 5K walk, and we usually we have a stroke survivor come tell their story, and then I usually bring some food, and we do it at the park. So when we get the flyers and stuff ready, so that's usually like the 3rd week of May. It's always technically on a Saturday, but like I find that if we do it like a Thursday afternoon, people will come over on their lunch break and stuff and come walk. So, but yeah, that was my little plug for Strides for Stroke. But yeah, so we're a acute stroke ready hospital, so that we are designated through the Minnesota Department of Health. We have a stroke medical director who is Dr. Janella. He's our an ER provider. And then we do neurosurgical consults through Telestroke. So it's a telehealth consult with a neurosurgery and group that's actually through Fargo. They live in Fargo. And then I do stroke review, again, policy and education.
Is it through Sanford?
Nope, it's through Essentia, and they're called like a Kern group.
Essentia.
And they sit in Essentia Health in Fargo, but it's for neurosurgeons that primarily do just stroke for our system. Okay, so these are 2 scans of stroke, and that first one is what we call an ischemic stroke. So the 2 major strokes, one is going to be a blockage and the other one's going to be a bleed. So the ischemic stroke is usually from the narrowing and closing of a vessel or a blood clot that occludes a vessel, and then the brain isn't getting any oxygen or blood flow, creating that dark area, as you can see on the upper right. And then the hemorrhagic stroke, which is, that patient was like an obvious trauma. You know, you could see the external trauma, but there's many people that come in with hemorrhagic strokes that we initially think are trauma, like we think they fall or whatever, and then when we do the CT and the CTA or MRI, that we see that they were a hemorrhagic stroke. And so that's a bleed. It could be an aneurysm that bursts. It could be like a blood vessel that bursts open, and a bleed on the brain. So again, the ischemia, which is the death of the tissue, is going to look dark, and the hemorrhage is going to look light on your scans. Okay, so stroke alert. So you guys know Be Fast, or that's what you guys are looking at when you are going to find a patient that has, sudden left-sided weakness, slurred speech. I'm having a stroke. I just can't breathe. Facial droops, weakness. Those are really those kind of fast criteria. Be Fast. Many people use just Fast too. I want to talk about the other one. So if you hear the LVO, that's large vessel occlusion. So think of our brain. I always like to, we have our big vessels that are going to their brain. They're started out with the carotids, and then you got your big vessels that are going to each part of the brain. We have the ability to pull clots out of those big vessels. From every one of those these big vessels, you have like hundreds of thousands of little vessels that are hitting every fold and crane, little nook and cranny in your brain. And so we can't get anything into those, and that's when we use thrombolytics. So there's 2 ways to deal with a stroke. If it's a large vessel stroke, we might see these type of symptoms. So they're the VAN. So vision, aphasia, and neglect, plus weakness, meets the VAN criteria. So vision could be like gaze, like a left or right gaze. difficulty naming objects like that you typically like, like when when you're in there with the ER provider, he's like, what's this? And some people will like, they want to say it, but they can't word find. And then ignoring or neglecting any part of the body. So a little bit of a timeline. So when our stroke consultation is emergent in that first 24 hours of symptoms starting. So the first 4.5 hours is what we call a tier 1 stroke alert. And this is the evidence-based time that we can use that thrombolytic medication to try to clot bust that clot from the brain so that the blood can flow to those areas of the brain. But anytime after that, there's evidence of the bad outweighs the good. Because if you think you're giving them a medication that's going to bust up and really thin your blood out, where else could it cause problems? Like, you can't just give it to the blood that goes to the brain. It goes to your whole body, right? So if the symptoms, were 8 hours ago or when they last went to bed, we don't know. There's risk to giving them that medication. So our guideline is with the last known well is within that 4.5 hours. And we give tenecteplase. Some, I think Cook might still give alteplase, or one of the hospitals up here. So we do have a regional stroke alert that we have, like you can either give tenecteplase or alteplase. But in Virginia, we do give tenecteplase, which is just a weight-based push medication based aside or like different from alteplase, which is you give a bolus, then you'd have to hang the rest of the medication. It was very intimidating to give. So we actually in 2019 switched to tenecteplase.
Well, it's terrifying to give anyway because
Yes.
you don't know the outcome, and
Mm-hmm.
Absolutely. That's why finding out the last time known well is so important to, whether they can give that
Yeah.
or not.
And I was going to talk about this because I think last time we came, we had like a lot of questions about wake up strokes.
Mm-hmm.
Like, what do we do with that? Like, when do we call it the last known well? And one thing I said, so the accurate time of when the patient or family reports to them be like their normal self. And so if they woke up and there was no like evidence of them saying like, I went to the bathroom, I felt fine, then all of a sudden I didn't, or a family member seen it, then the time that they went to bed is the last known well. So we do have, and we did have like even today, so this is before I even wrote that, we have many times of CT downtime at our hospital. So it's like, what do we do then? And I wanted to talk about this because we do have these like wake up strokes that even walk in, or if you guys bring in before and like we don't know that CT is down. If MRI is available, we did create a protocol to do what's called a fast, fast MRI, fast stroke. And it takes like these certain slices to be able to tell if they have like a bleed or not. So I did work with radiology to kind of create that based on a recommendation from the Minnesota Department of Health when they came and did our review.
And those are just usually typically weekdays, like
Monday through Friday.
Okay.
Yeah. But yeah, so we actually had like 6 hours of CT downtime today on like our injector thingy broke or whatever.
Oh.
And you know what I mean? So like there's a lot of times where we don't communicate it fast enough, or we have people here. And then so one thing we've done some drills about and talked about is like, where do we send this patient then? Or if you guys are getting this call, what, feel free to call in to us, talk through the symptoms, and then they can kind of give you like Aurora or Duluth, or like where to go. We've come across a lot of situations where like that timeline becomes really important. So if, their symptoms started like, last night, which was, 12 hours ago, like we might be like, okay, head to Aurora, like maybe their NIH is 2 or 3. Head to Aurora, get to that CT, and then we can bring them to Virginia if we need them. But if we're still in that 4.5 hours and you can make it to Duluth in maybe that time, and they have like a really high disability score, like don't waste your time trying to find a different CT. And that's of course if we have CT downtime. We want to get that patient to CT, get them that connected place if they're within the time frame before we send them down. And then the LVO is within that 24 hours. We're able to go down to the cath lab and able to actually go in and pull that clot out of the brain, which is really cool to see. If you're ever have the opportunity to pop in the cath lab and watch, like they can go from like an NIH, which is a severity of a stroke scale of like super high disability, like neglect of one side completely, to 2 or 3, where they can move around, talk, and all of a sudden become animated because their blood flow was returned to the brain.
I was lucky enough to see that on my first EMT ride along.
Really?
Oh, wow.
Yeah,
For
that's
STEMI, but
Yeah.
yeah,
Cool.
that's awesome. Any questions on this?
Is
This
it-
kind of looks confusing, but I just wanted, like, the timeline continuum is really that 4.5 hours. If knowing that, like, really precise, we can give them that clot busting medication to hopefully get the severity of their disability down. And then within that 24 hours, we can still emergently get them down to St. Mary's to get the clot pulled out.
Is it still considered best practice to go to our protocols always stated get to the nearest
Yep.
CT scanner, so that would kind of depend on where we are in our area, whether Hibbing or Aurora is gonna be closer, and then they can deal with flight or whatever from there.
Yep, no, Aurora's acute stroke ready hospital as well. And Hibbing, I think they are acute stroke or primary, I'm not
They're
sure.
acute stroke.
Okay, and so, yeah, so we all are trained we have to train our nurses a certain amount of hours per year for stroke care, and including that Tenecta place. So any place you can get them, they have these very similar protocols. And then I talked about Tenecta place, and I talked a little bit about that drip and chip. So this is our regional protocol. I know you guys can't read it, but I just wanted to kind of show that there's the two different, the Tenecta place and the Alta place. But yeah, we do Tenecta place. Our biggest thing is our door to CT. We're always trying to get the door to CT down to less than 15-20 minutes is our goal. And then door to Tenecta place used to be 60 minutes, and now the state is saying we're like hitting that out of the park for most people, so it's 45 minutes is the new goal in 2026. What do you guys, so you typically would never transport a post-Tenecta place patient, but even bringing in a patient, really like vital signs and neuros also are gonna be like a huge thing to report to us and get that baseline so that we can kind of keep them on like every 15 minutes, especially for that when they first come in or when they first get Tenecta place. We really wanna monitor that. And as we know, like we're giving them a huge blood thinning medication. We're looking for bleeding risk. We're looking for edema, any type of indication that they're bleeding other places. So can we think of some examples of like a person we would know right away couldn't get Tenecta place? So like if you're picking up someone and you're getting some medical history on them, like, well, we know they can't get it.
Age, blood thinners, recent trauma,
Yeah.
surgery.
Huge one is recent surgery. So like they're already like vulnerable. They're already on like the Plavix for AFib or heart things, exactly. So that's like a great thing to kind of come in knowing too, is like, okay, so we're not like racing the clock for that to take place. They're on blood thinners, they've had a previous stroke, and they're, you know, already coagulated. And then, so commonly missed stroke alerts. So we get probably like, I would say a majority of the strokes that we get, we do catch coming in a stroke alert, but we do have, I would say, like 10 cases a month where we didn't call alert, and then we end up like getting a CT an hour into their stay, and like, you know, like stroke. 10 is a lot, maybe like 4 or 5 when we're looking at all of our strokes. But pulling that data, the ones that we miss in Virginia, so typically we won't get them like in to CT in time, are the visual changes when they're coming in with visual changes, dizziness, weakness, and headache. So these are all symptoms that could be a stroke and that we typically miss. So how can we be better at catching those? And it's really looking at their risk factors. So asking that medical history. Have you had a previous stroke? How sudden did this come on? That last known well time. Doing a family interview. So a lot of these people who are coming in confused, like, is this a sudden confusion? Like, has this patient, you know, like had a dementia history, things like that. And then looking, of course, for us, looking up their medical history and seeing like, you know, giving indication of maybe this could be a stroke for a patient. Because we know, and this is our next one, time is brain. So that's the big like campaign around stroke, is that as minutes pass, you're losing brain capacity and your disability starts to go up. So these are just some of the different PI and factors that just from our hospital. So patients who come into the ED via EMS on average get a CT 19 minutes faster than those that walk in. Missed stroke alerts can delay treatment and imaging for up to hours if we're not asking those probing questions. Ages 65 years and older are less likely to call EMS with acute symptoms or delay calling compared to those in a younger age bracket, which that was like surprising to me. And so really when I'm trying to get out there in the community, I've been doing like the senior expo and going to like nursing homes or assisted living, because these are the patients that aren't thinking of stroke symptoms as medical emergencies to call EMS. And then don't discount our young people. Strokes in patients ages 18 to 44 have increased 14.6% and like over 15% in that like 45 to 65 or 64 age range. We've seen a lot, and actually our last 2 stroke survivors that we've had at our stroke walk were younger than me. So those are people like, one was a nurse that worked at our hospital, and the other one was a good friend of mine who also works at Essentia, but both younger than me and have had strokes, ischemic strokes. Any question on stroke?
A gal that some of us in the room know had a stroke last week, I believe, and didn't call EMS. I would say she's early 50s.
Okay.
And had her family drive her to the ER and ended up getting T&K and shipped her down to Duluth, and she's fine.
Okay, I probably reviewed her case.
Yeah.
I know, it's whenever I see like the ages, I'm like, you know, like that could be me, or like that could be, so.
My son's stepmom was 27, and she had.
Yeah, that's crazy.
Mm-hmm.
A lot of, you know, we think about like the medications that, you know, especially with these young people coming, some of it can be congenital, like heart issues that were never diagnosed. So you can't, I don't know, with the one patient that was around my age who, she was out in Wisconsin Dells, she had a, like dizziness to the point where she had to like get down to the ground, like she like felt like she was gonna fall, so she went to a local, ER, they gave her like a migraine cocktail, sent her home, she like felt a little bit better, but then the dizziness kept on, happening, so she ended up going to Aurora, they did the CT in Aurora, and yeah, she had a ischemic stroke, and, will probably be on blood thinners the rest of her life, which is, someone who's young and active, like that can be like not like a little bit of a, a drag, like being on blood, that you have to be careful about things that you do. It's not, they don't know really what caused, like her stroke, but we're seeing it a lot in our young, 14% more, even just in a decade, so.
And they don't really have are they leaning toward any kind of cause, like is there a change in birth control that may be causing it, or?
I think that for women, I think they're looking at a lot of like hormonal things and things like that can change postpartum, the hormone changes, the blood changes, like that's huge, like, and so I think for women particularly, they're looking a lot at those things. We don't know what like vaping has, contributes to. I know like I'm always like, I used to be a smoker, and like I quit 10 years ago, but like that's the first thing I look at when, and I pull the data too, is like, are they a current smoker or former smoker, or do they vape, things like that, because that's data that like is actionable, in our community, is that we can show like this links to, so and I think 62% of my stroke alerts are either current or former smokers. So that's a huge risk factor. And then with the young people, I always check about vaping, because we don't know what like that has, what medical things that is still yet gonna cause. So
I wonder about like energy drink consumption in the younger level too, like
that could definitely throw a clot, like in, if we're thinking like we're, increasing our heart rate, rapid heart rate, if you already have like a predisposition to clots, or, like sedentary lifestyle, and then you're throwing on these like adrenaline, drinks, like, yeah, absolutely.
That's a good thought. Good thought of that.
And then, a drug history is a huge one. When you see that, like, you're throwing chemicals in a body and it just kind of, I've been telling my family a lot, because, I have some medical family and some not, but I'm like, your body isn't compartmentalized. Like one thing affects the way your body works, like it's not, like my diabetes lives right here, and it's on, you know what I mean? Like, no, that affects your whole body. That affects why you get sick. That affects why you can't heal, and so I think about that a lot more now, constantly explain it to my parents. Like I think about it a lot more with my patients too, like, and looking out and kind of looking for that, like, health equity opportunities to teach in our community, that it's not just like, the same old, like, dietary and smoking, but also what other lifestyle changes you can make, and dietary things. And I just recently got back from the International Stroke Conference. It was in New Orleans this year, and so that was really cool to kind of hear the different like hormonal therapies in women, that for many years we listened to one study that estrogen caused breast cancer, in the 1990s, and ever since then we stopped replacing hormones for women that are going into menopause, unless like their symptoms are really terrible. And so I don't know, I feel like I've been like a women's advocate lately, of just like, getting that checked out, and and not letting it progress to osteopenia in these women or cardiac issues that could lead to strokes or to heart attacks and things like that. That catching those hormonal changes before you're outwardly showing like hot flashes, mood changes, things like that, those are byproduct of a late hormonal imbalance. And so, and then I saw, at the stroke conference, there was a huge talk about that, and I was just like, yes. Like, so when you're done having children, women, go get your hormones checked, and, talk to people that have done research that's, not from the 90s.
Right.
Yeah.
Dr. Keith is still on top of all that.
I bet he
He's
is.
still on top of
That
it.
does not surprise me.
Can't believe he's like, I think
He
My-
delivered me.
he delivered me too, so I'm
He's
sure.
Yeah.
90, he's still practicing.
Yeah.
I know, cause I see him,
Yeah.
Is he at Scenic Rivers?
yeah.
Yeah, I didn't know he's
That's
I didn't
what
realize
Shakes is
he
trying
was
to
still
do.
practicing.
He's 90 years old. He's a good 90 though.
Mhm.
Yes.
Amazing.
So,
I know.
Leah,
Yeah,
did you ever see the one, when we had the cold snap, there's a friend of Laura's, had a dual hemispherical stroke.
okay.
Brought her, she waited like 28 hours to call.
Mhm.
Ended up having, affects both sides.
Okay,
Laura found out from family.
yeah.
She had blocks both sides.
Oh my gosh.
Yeah, in those
The
situations,
son made her call, cause she lives in a tiny house on his property and refused to call the day before, so.
Like April or? Nobody knows.
She had 2 meds, both for anxiety.
Oh jeez.
Yeah. Yeah, you typically with that, like when there's just like, you think like blood clots like from the heart or, somewhere where like your blood, like it's not, usually when it's like sudden right side, that's gonna be like they'll look and like they have had junk blocking that, and there was just like a little bit coming and it finally a little clot or a little part of the junk that was collecting in the vessel, like, occluded it. So that's really when you see like the right side or the left side droops and things like that. But when you see it both sides like that, I always think, again, I'm not a neurologist, but I always assume like clots from the heart or the legs or something
Something
like
in the
that.
shower.
Mhm.
Went through dual clots is what we were trying to figure out
Yeah.
when Laura found out about it.
Oh.
It's like, but again, you wait so long, and of course, everything's negative on every stroke scale you use because they're even.
Yeah, right.
There's nothing to go by.
Yeah, that's hard. So STEMI, so that's a type of heart attack. It's one of the most serious heart attacks. It has a greater risk of complication and death, and it's that ST elevation. So you have that QRS, T wave, and when you have that ST elevation, we know that there's ischemia in that part of the brain, the part of the heart. I hang this in our emergency room and in our triage as who needs that EKG. And really this kind of builds off the bottom and goes to the top. So an 18-year-old who's coming in and they're saying like, I have pain in my chest, you know what I mean? Like, okay, let's get an EKG stat for them. And then when you're older than 30, basically any chest pain, anywhere in your chest, if you're having pain, we need to get that EKG. And when you go down to your 80s, basically any symptom can really be masked as cardiac symptoms. So really be an investigator, and we use this and we get that EKG, probably more than we need to. I would say, especially people that are doing them are like, really, another EKG? But these are the evidence-based symptoms that we're finding.
And I would have to say that we do very, very few 4 leads. We are really good at doing 12 leads and taking them appropriately.
Good.
And, very few missed ones. So that's kudos to
Yeah.
our whole staff. 'Cause we're
Absolutely. And
super
that's
good
so
at that.
helpful to like when you can,
Oh, yeah.
you can transmit them here, we can look at them, we can like, okay.
Now that we have it
Yeah.
figured out, right?
Yep, yeah, I did talk to Brianna and she, yeah.
She's our hero.
So when we're looking at EKG, we're looking at like the different areas of the heart. And so when we see that ST elevation or depression, we can kind of tell what area of the heart is being affected, which is kind of cool. So you got your, anything up here in the V1 through V4 is gonna be an anterior. It's the anterior septal part of the heart. And then the, leads 1, 2, or 2, 3 in AVF, that's gonna be an inferior infarct. So I wanted to just, I don't know, can you guys see?
I can see.
Okay,
Yeah.
so looking at this, do we see any areas of ST elevation? So this was actually a recent patient.
Yeah, I can see some of the top for sure.
Yep, so what we're looking at is gonna be in our V1, V2, V3, we can kind of see right there that ST elevation. And remember, V1, V2, V3, that's gonna be an anterior heart. And then another trick to kind of like, if you really feel like, well, I don't know, maybe like I see some ST elevation, look at the reciprocal leads. So when you looked at the anterior versus inferior, you should see depression in the ST depression. So it kind of mirrors itself. So you'll see the reciprocal ST depression in 1, 2, 3 in AVF if you have that elevation in V1, 2, and 3. So that's just something to like, if you're looking at one and you're just like, I don't know, look at the opposite leads. Like, do the mirror, because it's kind of showing you a mirror of the heart when you're looking at the anterior and the lateral. So if you see that depression, you can kind of be more confident that you see the elevation. Does that make sense?
Do you still have those? We used to have cards like we still do, that go on your badge, that it shows like 12-lead placement, and then on the,
Yep.
what's on the flip side of
It
that?
shows where it is, whether it's LAD.
Yeah, that little chart,
Yeah.
the color.
I-
Anyway, we're out. I'm
Yeah,
wondering if we can get
I'll
more.
look, yeah, cause I'll look to see, and I
We
think
got
I do
ours
have
from
some in my
North,
office. Huh?
I can see.
We got-
Ours are from North. I still
Oh.
have mine, you can't leave it.
Oh, that's a different one.
Yeah.
There's some that were put
I
out
still know
by,
what's where.
Mission, whatever, what am I
Yep,
thinking of?
Mission Lifeline or.
Yeah,
Yeah.
the same one with the STEMI program, the red book.
Yeah.
In fact, if you have any more of those too.
Yeah, let me take a look, cause we used to, like in that trauma area room or whatever, we used to, I think, is it probably your old office?
It
We
is.
used to have, a ton of stuff in there. And I felt like I asked, Richard if there was like updated, cause I hate giving out like, of course I would give it to you guys, but like I wanna make sure I'm giving out like like the most updated resources too. So I'll check on that
Okay,
again and I'll,
thank you.
yeah, connect with you.
Remember laminator trees?
We do not. We should buy one
So you
now.
just print one and print a couple and laminate them, tape them up in the ambulance.
I ordered some really cool ones off of Amazon too, that's en route to me, but they've got like the Be Fast, and then it's got like certain
Oh.
things to do with stroke patients, like the,
Oh, yeah.
Yeah, I've seen them
Oh,
like
cool.
$2 on Amazon.
yeah, they're not expensive at all. I'll show you when I get them.
Oh, well, if you don't have any, then I'll just order some.
Yeah, I'll take a look. But this is actually the patient the EKG that we looked at. So it was a 51-year-old male with stuttering chest pain for months. So he waited to come in. But today, even at rest, he was having chest pain and it was extending to his neck. He had shortness of breath with dizziness, fatigue, weakness. So they drove him in instead of calling EMS. So they drove the patient in, and then we did get that EKG within 8 minutes, which our goal is 10 minutes to really get life flight started. And then, so the PCI is when at the cath lab, these are the images they're taking at the cath lab. and you can see his LAD. So remember, we thought that was the anterior part, so we see that it was just blocked there, and then that is actually after they put in the stent. You can see how much more blood flow is. I love when they can add these. Like they don't always get great pictures, but when they do, it's so like, oh wow, you see the difference. They do have those for the brain too. We don't typically get them, but it's really cool when you can see them post in the cath lab, like when we have the LVOs, the large vessel occlusions. So this is the DASH protocol. So this is a protocol that's a regional protocol again. Of course, you can't read it from here, but it's really just saying, get to the nearest hospital, get that patient to a cath lab. There's two different, there's the primary PCI, which is gonna be the thrombectomy, which that is gonna be like our first choice. Now, if this patient is in Ely and they were out in the woods, their chest pain started, like an hour ago in the woods, and it's going to take them, it's a blizzard out, it's going to take them an hour to get to the hospital, then 3 hours to get down to Duluth. The other options are fibrolytics or like the T&K that we give our stroke patients. We will give for cardiac patients too, to try to bust that medication or those clots.
So if you would give that for like a STEMI, would that like increase the risk of like the clot going somewhere else, like maybe the brain?
Well, hopefully it would like thin out the blood enough that but yes, that's absolutely, so even like for the tenecteplase, even like when we give it for strokes versus heart attacks, we're still doing those neuros every 15 minutes after, because we want to make sure we're looking for the sign of bleeding for angioedema, things like that. That could mean increased bleeding, or again, like the neuros, it could be another clot going to the brain or even to the, but the hope is that it's gonna bust them, like it's gonna thin out the blood enough that you'll start getting blood flow. And then sepsis has been ignored as a medical emergency for a long time. It is in Essentia and across hospitals nationwide, it is the highest mortality diagnosis, of all of a diagnosis, most people are dying of sepsis. So early recognition is huge. Even some rigs are starting to carry antibiotics, to start antibiotics even before they hit hospitals, because really early recognition and treatment of sepsis is going to help save that life. And so sepsis is, I think I put it on here. So the stage is sepsis. So sepsis is an infection that's out of control. Its symptoms include fever, mental health decline, or mental decline, not mental health, mental decline and extreme illness. But basically your body, the infection has got into the blood, your vessels start to get leaky, your blood pressure plummets, and your organs, we call it end organ damage from sepsis, are not functioning because they're not getting blood or oxygen. So it goes from, this patient's coming in septic, they're in severe sepsis, so you're starting to get signs of organ dysfunction. So that could be your kidney numbers are way high, or trouble breathing, your blood pressure is plummeting. And then we have shock, when your blood pressure drops too low to not be able to support life. And so we really have been pushing a lot of education that this is a medical emergency. It's time sensitive, just like our STEMIs, our traumas and strokes. So what could you look for out in EMS, picking up these patients? Recent surgeries is huge. Any type of thing that could invite bacteria or infection into this patient. Respiratory symptoms, a really productive cough. Antibiotics within the last 2 weeks. Indwelling lines, catheters is a huge one in our elderly population, or if they have ports, or chemo patients, that can be a huge one. Positive blood cultures, or they report that they had positive blood cultures, wounds, cellulitis, pressure injuries, UTIs. Vital signs to look for is going to be tachycardia, tachypnea, hypotension, so low blood pressure, like increased respiratory rate, elevated temperatures, or really lower than normal temperatures can all be indicative of a sepsis. So of course, the sooner that we can we have a BPA that fires, which is a best practice alert in our Epic. So as soon as that fires, we're on the clock to getting that patient's blood cultures taken, antibiotics given, fluid resuscitation, so that we are supporting the circulatory system to provide blood and volume to our organs.
What's the antibiotic of choice for that?
Like Rocephin, or like, I think it's going to be really dependent on where the site of infection is, but I would say like penicillin or amoxicillin, things like the broad spectrum antibiotics for what if you don't know. But when you start, like, is it pneumonia or things like that, you're gonna kind of narrow it down. But yeah, you're gonna start with your broad spectrum antibiotics. And then cold blue, it's really, there's nothing like, mind-blowing to like educate you guys on. It's really things that we learn every day in BLS is that chain of survival. So that early access, so getting that call in, like doing that education for our community to like call with the chest pains, things like that. Starting early CPR, early defibrillation, and then advanced care. So getting them to a hospital as soon as you can. Like, I wish there was something a little bit more interesting when it comes to rapid response and resuscitation. As it relates to trauma, blood pressure is huge. We need fluids in that patient. The biggest death sentence for a trauma patient is going to be the loss of blood volume and hypotension. So hypotension is what kills most trauma patients. So getting the blood pressure up, and then prioritizing C over ABC. So when you see uncontrolled bleeding, you're prioritizing that over airway and breathing and then circulation. So I don't know if you guys, have you heard of prioritizing C over ABC?
Mm-hmm.
Okay.
It's usually called CAB now.
Okay. Yep. In trauma or TNCC that we take and stuff, that's how they word it, is C over ABC.
Cool.
And then stroke is that medical history, getting us that last known time well, so we know whether they're in, or like, after resuscitation, of course, like, then we're starting to do our investigation. So when you are resuscitating a patient, there's some underlying, usually, there's something underlying why their heart failed. And so we want to know, is there a course of cause of infection, I think I was supposed to say there, but infection, or was it a chest pain? We need to get the EKG so we know what we're dealing with if we do get ROSC on that patient, which is return of spontaneous circulation.
Do you case review like cardiac arrest? We get two, or is that like?
Do I what?
Do you case review cardiac arrest?
Do I like review them?
Yep.
Yeah. Mm-hmm. So every cardiac arrest that comes in our hospital, yeah, I review. Yeah, there's not a gold standard. Like, I look at the ACLS algorithm, I make sure that we're hitting it. Like, like the goal is always to be like, organized, not, not chaotic, things like that. It never is. Like, everyone, when the stars align, we have it's like a really great situation where, everyone's doing their roles perfectly, but it's always kind of just like a little bit of unorganized chaos when it comes to resuscitation. So it's, every patient who comes in isn't following the ACLS like guideline, you know what I mean? The way that we think that we practice, like when we practice BLS, like there's always something that throws it. Like it could be a trauma, it could be an open wound, it could be, you know, we're unable to intubate or get the airway. And so it's like, you have to have, like, when you're looking at that, you just have to have a lot of like understanding and grace that like everyone is doing the best they can when it comes to resuscitation, and it doesn't always look organized. But yeah, we talk a lot about debriefing after resuscitation, and that's something like I, you know, really push on my nurses, is make sure that we do that mental health break, that debrief after like a hard resuscitation or even an easy one. Like, what, you know, pat your guys' self on the back of like what went well, and, you know, talk about the things that didn't go well with like an open mind, because I think that's how we learn, and that's also how we get it off our chest. So if you don't want to carry that, you know, or your career in healthcare won't last long. Like you just, you know, it becomes way too much if we carry that. So anytime you guys feel like, you know, reach out to me or Hannah Adams, she's a supervisor in the emergency department, like reach out to us about like, you know, if you're looking to do a debrief on a patient, or you want, you know, you want to know what happened once they got here, I'm happy to follow up with you guys, or we can, you know, do a formal debrief within the hospital. Yeah, but that's really all I have. Does anyone, sorry, I probably went over time, but
No, that was very good.
yeah, do you guys have any questions for me, or
No, I think it was good.
yeah, or feedback? I always want feedback of like, you know, I should be better about preemptively sending you guys feedback, but usually it's the big cases we're shipping out, and I'm waiting for feedback from St. Mary's. But yeah, so reach out, like,
which isn't always very timely,
Yeah.
if at all.
Yeah.
I mean, most of our trauma reports that we get back, I get 0 stroke. I mean, never. But the trauma ones that we do get are 4 or 5 months later,
Mhm.
you know, so it's like, holy smokes, does anybody remember this?
So
You know?
they do have new PI coordinators, or they at least one extra or a new one. So
Sid, is that Sid?
Sid, yeah. So I'll keep in mind and try to remember who it came from, and then I'll forward it if you're not getting it.
Perfect.
And I'll talk to Sid too. Same with Lori Ballman, is who sends our stroke feedback from. And so I only get feedback from St. Mary's on our treated cases. So if it's tenecteplase or a thrombectomy, I'll get feedback. And typically it says on there who brought them in, so I usually CC them in, but I'll make sure I'll double check
That'd
too.
be awesome.
Yeah, absolutely.
And you know, Air Medical used to be really good. Both North and Link would send us, like if we flew from the scene, or, you know, hand it off to Air Medical, they would get reports like sometimes right away within hours, and they would always call and be like, hey, here's the scoop and this is what happened. And I think that brings a lot of closure too for our providers. You know, it's just like, did we do the right thing? Did I miss something? What was the cause? And you know, whatever. But that's not happening anymore either. And I have reached out to them, you know, but that feedback is really important to us, both, you know, as like you said, for our mental health, even, you know, just, and education. It's, you know, like, oh my gosh, that was that. I wouldn't have even, you know, or they're huge. So the more that we can get, the better.
So, yeah, next NERTAC meeting, which is our Northeast Regional Trauma Committee, I'll bring that up. And yeah, so I know Mindy is a member who I think she's one of the managers or like a supervisor at Life. And then someone from Northern Memorial does come too. So I'll talk to
Ty Wigman goes from North, or no, he goes from Lifelink.
Okay.
And oh God, who was the North one? I don't remember. Anyway, yeah, or else I can bring it up to it. When is the next March? I think.
I feel like there was a big break. between the last one.
Well, if you're not around, I can bring it
Yeah,
up too.
yeah, I might be gone, but.
Uh,
This is your computer. Okay, well, thank you guys for
Thank
having me,
you.
like, yeah, please, yeah, I love doing this, but it's also a check off on my designation criteria to like, that I'm doing some EMS education and kind of, working with you guys, so I'm always open to feedback, good, bad, or otherwise, so.
Wonderful. Thank you so
Yeah,
much.
of course.
And please let us know when you